Hello, everyone. My name is Gilberto Filsinger. I'm a student at Truman Medical Center School of Nurse Anesthesia, and the focus of my quality improvement project is on the use of ketamine as treatment for tourniquet-induced hypertension, more commonly known as tourniquet pain. In the following presentation, I will provide an overview of the pathophysiology behind TIH and why preemptive treatment with ketamine is a good option. Let's start by understanding what tourniquet pain is. The term tourniquet pain is a common umbrella term used to describe the hemodynamic changes that occur with prolonged tourniquet use. It is more specifically referred to as tourniquet-induced hypertension. Patients often describe it as a diffuse, vague ache in the occluded limb. Most peer-reviewed scholarly literature define TIH or tourniquet pain as an increase in blood pressure of 30% or more, and some mention an increase in heart rate as well. However, the change is not specifically defined, and none of the studies included in this project used heart rate as basis for treatment. When a tourniquet is inflated, A delta fibers become mechanically blocked at around 30 to 45 minute mark. This allows for repeated uninhibited stimulation of slow transmitting C fibers. Additionally, injured cells release prostaglandins that increase pain perception by sensitizing and exciting pain receptors. Also, limb ischemia causes central sensitization via NMDA receptor activation due to repeated nociceptive afferent input from the affected limb. Altogether, these conditions contribute to the condition known as TIH. There are a couple available treatments and some ways not to treat it. Opioids are ineffective in treating TIH because they do not decrease the vesicle excitosis in C fiber terminals. And as one would suspect, deepening anesthesia has not shown to effectively treat TIH either. Consequences of incorrect treatment could lead to opioid overdose and the respiratory events that follow, increased postoperative pain. As far as good available treatments, ketamine, magnesium, nitrous oxide, ketorolac, and dexmedetomidine have shown good results. So why is ketamine better? The study by Takeda et al. And awake patients were able to tolerate their tourniquets for 11 minutes longer, or plus or minus 7, compared to a placebo. And in Kumar et al., patients under general anesthesia did not demonstrate TIH at all. Ketamine is an NMDA antagonist, which, as we have learned, should be a target for treatment of TIH. It does not cause cardiorespiratory depression and has an established effective dose. Magnesium is a known NMDA antagonist, but there are some literature that show it could prolong muscle relaxation and hinder extubation, and also muscle weakness that could hinder recovery and physical therapy after use of the tourniquet. Nitrous oxide has also shown some NMDA antagonism. However, the mechanism is unclear. Ketorolac can also be used as an adjuvant due to anti-inflammatory, but it is not used as an effective primary treatment for TIH. And it can also precipitate bleeding and anaphylactoid reactions, which may be contraindicated in some patients. Dexmedetomidine produces some A delta and C fiber blockade, but the effective dose has not been yet determined. So why do providers not use it? The number one reason is because ketamine is known to produce psychotomimetic effects. These large doses of ketamine can induce psychosis at anesthetic doses. However, in all studies combined, 113 participants received low-dose ketamine, and only 2 of those who received low-dose ketamine were IVRA patients receiving a beer block. They were awake and they experienced restlessness only immediately after tourniquet release. So there is an evidence-based effective dose for low-dose ketamine. One method used in the studies was an initial bolus of 0.1 milligrams per kilogram 10 minutes before tourniquet inflation, followed by an infusion of 2 micrograms per kilogram per minute starting at tourniquet inflation. The second method was just a one-time bolus of 0.25 milligrams per kilogram. And the third method, given to patients with under IVRA, or intravenous regional anesthesia / beer block, was a one-time bolus. It was a mixture in a 20 ml syringe of 2% lidocaine mixed with ketamine at 0.5 milligrams per kilogram. So in conclusion, there's little evidence to support that low-dose ketamine can produce serious negative psychotomimetic effects. There is good evidence supporting ketamine's advantage over other medications commonly used as treatment for tourniquet pain. And it is important that the anesthesia provider understand the evidence supporting ketamine as treatment for TIH. This can help our patients recover from surgery, experience less pain, and have a more positive stay at our hospital. This educational project hopes to encourage providers to include ketamine in their future anesthetic plans with more confidence. And here are my references. Thank you very much.